How great does it work? I'll try to make as concise as possible, to be honest. Oh, it doesn't work again. How? Please do something. Oh, this is the button, right?
Just one moment.
No, just one moment. And the meter has to be calculated in the time of presentation, the kind of actions. Right. The front approach. Hello. Can we go back? All right. Can we go back a little right now? All right. Oh, okay. Let's start. So ECMO is the best option, of course. We've been talking all around, and I think it's an unanimous decision that one of the best options for acute heart or pulmonary failure is ECMO because of various reasons. You can see that can be cardiac and pulmonary failure can be converted, can be used as temporary, can be used as a permanent or bridge to transplant. It's cheap and it can last long enough to provide comfortable decision making. And in Croatia, we have a long history of ECMO, actually started from 1987, unfortunately terminated in 1995, and then re-established in 2008. And from the beginning, it's been kind of merged or worked together with the transplant program and with the chronic pump program, and has been in development ever since. As the kind of physiological data hand-drawn, at that time laser printers did not exist for the first patient. Please notice ECMO off and the patient still alive, and there was post-cardiotomy, aortic valve replacement, low cardiac output patient survived with the ancient technology of the Kolobov type of oxygenator. That was possible, but to be honest, at that time were only anecdotal or occasional survival. Now, big picture in Croatia that they have, and as we have a nation program, but nationwide program, there's a definition of what's the nation. So roughly our area of responsibility is about the same as the area of responsibility of the Regensburg Center. It's about 4 to 5 million people that we cover. And there's a number of procedures started at the University Hospital Center, and at the same time started at the University Hospital for Infectious Disease, because there's a kind of holding that they cover veno-venous or respiratory indications, and we cover mostly vascular or circulatory indications at the same time. And since 2013, when the equipment was purchased by the Croatian state, the program picked up in other institutions, so we totaled up to 688 patients so far. For the population of 4.3 million is not that bad, right? And we here in Croatia developing our ECMO network started from two principal paradigms. I don't know whether everybody will agree with that, but our paradigm is for respiratory ECMO, there's always or almost always enough time, and the patient should be transported to the center of final treatment and then connected to ECMO. So in most cases, patient can be transported to the University Hospital for Infectious Disease on conventional ventilator. In rare instances, should be remotely put. Completely the opposite. In circulatory ECMO, there is not enough time because the main Bray resistance to hypoxia is only a few minutes, and then ECMO should be applied locally as possible and as fast, as quick as possible, and then not to maintain ECMO in spoke center and then transfer patient to the hub center for final treatment and risk. And National ECMO Network is being, let's say, established, at least hardware has been purchased by the state in 2013 at the spoken hub principle. So there's one respiratory ECMO hub, and that's the Department of Infectious Disease, and spokes all hospitals with cath labs and some district hospitals even without cath labs. So all cath labs in Croatia, they're equipped with transport type of ECMO, that's cardio-help. And circulatory ECMO hub, all university or affiliated hospital with cardiac surgical service, there are 5 of them 4 university hospital centers and 1 university hospital in Zagreb. So 2 in Zagreb and 3 regionally. Right. So that's a kind of map. You know, Croatia is a very, very funny shaped country, and from the far east to the far south by roads about 1,600 miles, something like that. It's very difficult to establish the principle of these mobile teams to go on some kind of short notice basis and to travel anywhere. And we believe that's our principle to train as many local people to initiate ECMO and then patient to be transported to hubs, well, suits our needs in Croatia. And that's a kind of depiction of the 150 kilometers. So most of the territory is being covered by hubs and with local spokes, a part of far south of Dubrovnik and some uninhabited parts of central Croatia. So virtually any Croatian citizen can be put on ECMO in spoke center and then transferred to hub for further treatment, and only in those hubs who can do upgrade, who can do any kind of decision make or exit strategy, they're available, exit strategies were they're available. 32 consoles were put and Maquet PLS in hubs. So in hubs, we don't use cardio helps. Only in rare instances, cardio helps are being reserved for transportation and for initial application because of ease of priming. For, for PLS, a professional perfusionist is usually needed for, as been witnessed in Croatia, for cardio help, it can be primed in a regional ICU unit and put or connect to the patient with any physician with enough knowledge of peripheral vascular access, right? So spoke center, sadistic ICU with or without cath lab, and of course features of the equipment as a very light and portable, transportable, and very simplified priming. That's quite important. And of course automated vacuum control, that's also important. There's no problem in hub centers to have a manual vacuum control with PLS because we have professional perfusionists and nurses in the ICU, they're highly trained. But in district hospitals, it has to be automated as much as possible. And however, patients can be transferred from one hub center to another hub center if we decide to some exit strategy which require permanent VAD option or transplant option, right? And hub center, mostly we use the PLS. Well, very important reason for that because PLS is modular. So can be used surgically, can be used as a peripheral device, can be used as a central device, can be used as left-sided ECMO or right-sided ECMO, so any combination is possible. Can be converted with a kind of only pump, so oxygenator can be removed and converted to the paracorporal support, so everything is possible. But it needs a little more of expertise locally. Well, we have. So, and that's again, right? So transports are slowly picking up. So of course, that's ideal, that's a wishful thinking, but in reality, training takes some time, but so far we have some transports and we have only three international transports because in Croatia, for exit strategy, we don't transport anywhere a part of lung transplant is being done in Vienna. So 3 transports from our center transported to Vienna. But we mastered that mobility issue as well. So we can do that now. And University Hospital Center in Zagreb, some numbers I'll show you. We organized in various departments, and there are 2 departments who put ECMO independently, that's cardiac surgery and cardiology. All other departments have been assisted even in connection patient to ECMO and perfusion service, which belongs to the Department of Cardiac Surgery, provides perfusion backup for all. But it has already become difficult, and we have to think about the next step, maybe to establish independent perfusion service or something, because it has become difficult to take perfusionists from regular service or in the middle of the operation. But of course, that's another cent, and that's our rough statistics that roughly 50% of patients survived in various either discharge or be upgraded or being transplanted, and that's the kind of fate of the patient who had been connected to ECMO, upgrade, transplant, weaned, or died. And our statistics is not much different than statistics in other centers, having in mind that confidence limits in such relatively small numbers are always very, very wide confidence limits. So in primary ECMO is very similar to the post-cardiotomy ECMO, and our overall survival does not differ very much for various centers. So one of the extreme examples what ECMO can be useful for is the kind of rupture of the left ventricle, surgically untreatable because it was completely necrotic left ventricle, and the Satinsky clamp was placed over the left ventricle. Satinsky clamp, that's a patient going out of the operating theater with a Satinsky clamp protruding from the chest and sealed with the Vaseline gauze for drainage, and a kind of this ECMO with additional left LA drainage line connected to the venous drainage line, and this EKG, right? EKG lasted continuous VF for 72 hours, and this EKG, of course, after successful transplantation, that happened. So ECMO, again, going back to my first slide, ECMO is the best because it provides complete cardiac and complete circulatory and complete respiratory support, and very quickly, and of course very cheaply. And at the venous, at the respiratory distress side, University Hospital Infectious Disease, they did 160 procedures, and of course number of patients are going up and up and up and up, right, anywhere, and the median and the DOB is age. Well, that's a description, age. The median age is going up as well, so we are keen or ready to treat elderly, older and older patients. And of course, mortality is being defined by precondition of the patients. So those patients with no CRRT, they have the lowest mortality. Patient with renal replacement therapy, they have a higher mortality. But it has been said elsewhere in other papers as well. However, it's a very efficient societal. It's simple to initiate, yet difficult to maintain. That drives the whole philosophy in Croatia has been driven by that. Simple to initiate, difficult to maintain. So initiate as peripherally as possible and maintained as centrally as possible. And of course can buy precious time for decision making, and short-term ECMO-related damage is acceptable, but only short-term ECMO-related damage. If you go beyond 30 days, there's very little hope for the patient. And the main dilemma is always the same, not to waste precious resources, but not to lose treatable patient. And that's, I think, it's a very deep ethical dilemma, because if there is a 1% of chance that ECMO can help somebody, I would initiate the ECMO. Actually, there is no dilemma at all whether we should defibrillate anybody at a public place, cardiac arrest. So the idea in our country or in our program, the ECMO should be considered not as an aid to other procedures, should be considered as a primary resuscitation tool. It will take some time that to happen, but I believe that with some kind of further simplification of vascular access and further simplification of priming procedure, that's accomplishable. And of course, it should be applied nationwide. Of course, it depends on the definition of nation. Nationwide, in our case, means few million of people. Probably in Paris, the area of coverage is much bigger than whole Croatia. But a few million people, that's our idea, and should be based on spoken hub principles, and exit strategies, of course, should be developed and applied, neither under or not overused. Is life-saving success rate as a timing of implantation is critical. Well, I would like to raise the question, or maybe to initiate discussion about the mobile team. So, because the mobile team, however efficient it is, it needs some time to come to the field. So whether we should rely on mobile teams or should rely on locally trained kind of ECMO initiation teams, or combine both those features. And say educational scheme should be organized, and chance, well, that's our mission. The chance for surviving cardiorespiratory arrest should be equalized to the whole territory of the Republic of Croatia. That's not easy and probably not accomplishable at all 100%, but we will try very hard to do that and to accomplish that. Well, thank you very much for your attention.
Any urgent question? Okay, thank you so much.
Well, so we move on to the next presentation, and again we have a 1-hour discussion at the end of the session. So the next speaker is from the hosting center here in Astana, and the topic is extracorporeal membrane oxygenation program in National Research Center for Cardiac Surgery. Thanks, Timur.
Dear distinguished board, dear colleagues, first of all, I would like to thank the society and the audience to have me here and to share with you our modest experience with ECMO. So I represent National Cardiac Research Center, Astana, and our big team is listed over there, but they are not all. In 2013, we had the gap, the big gap of ECMO technology in Kazakhstan. And as you see, this a huge map of the world, but a huge wide support from Europe to Japan, and we didn't have any ECMO center in this region. It means we didn't have any experience of ECMO in this region. Let me introduce our milestones, let's say, of our program that was started in 2011 when our center was opened, and the first case was pediatric case. We had a little girl that couldn't be weaned from cardiopulmonary bypass, and she needed ECMO for 97 hours and was successfully weaned and discharged the hospital. The next year, we first introduced peripheral VA ECMO for that patient, but that was only the first and then the second case. And then we, after restriction of that program and inclusion criteria for that program, now we don't see any case of ECMO requirement for that patient. The same year, we could transfer pregnant women with acute adult respiratory distress syndrome from far south of Kazakhstan to our center, and she had ECMO for a while and was discharged and delivered healthy boy. And the same year, we could extubate a patient. And since we introduced heart transplant program, our first cases weaned from cardiopulmonary bypass with the help of ECMO. The next year, after collecting some experience, we understood that we should share our experience and have feedback from reference organization, and we entered ELSA registry. Now we're citing there and get feedback in order to improve our results. And since 2016, we've organized local, let's say, reference center in order to share this experience for our region. But it was a catastrophe at the first period, at the first year, when we had 84% mortality and weaning only 38, but we discharged only 2 patients. That was a catastrophe for us, but we didn't stop, and we've developed a program. In order to bridge this gap between weaning, discharge, and death, we had to do something, and we developed a program, education. We changed management in operating room and in ICU, in intensive care unit, and we continue education and simulation both. So, what indication do we have in our center? We have to bridge to recovery, to heart transplant, ventricular assist device, that was at the early stage, and bridge to decision. The whole experience is in this chart. It may be quite complicated, but if this is the whole, our experience, we had 230 cases and 63% of winning. Unfortunately, we do not discharge all of them. We lose some patients and discharge 54% of patients. And mortality is still high, 44%. If we will, because of a lot of complications in each group, in coronary artery disease group, in valvular pathology, in heart transplant, in congenital, in adults, we have a lot of problems. Multi-organ failure, stroke, and bleeding. Bleeding is very high because we collect data and for bleeding all patients that required cell saver during the operation or in early postoperative period. So we all consider them bleeding. But we still think that central VA ECMO is good for our patients because of several advantages. First of all, because we have highly selected group for open heart surgery patients. We suppose that the top of the list is easy to switch from cardiopulmonary bypass in the operating theater, and it allows us any flow required for a patient needs. It is always biventricular support. It is low risk for cerebral and heart desaturation in comparison with the peripheral VA ECMO. Low need or maybe no need of left ventricle venting. We try to extubate the patients and try to perform a physical rehabilitation as early as possible. I will illustrate it in a few minutes. And we changed our management before operation. First of all, there's multidisciplinary approach. Rather than one person's opinion, we always educate patient and family before, and it is always planned procedure. When you have operation plan, we always add ECMO there. So we plan to cannulate aorta with flexible cannulas and try to do it in contrarapid manual. We try to avoid dilution. We inactivate heparin for maybe 24 hours right after the implementation of ECMO, and we try to stabilize the sternum. So this is the case. We didn't transfer the patient from the operation theater, and the patient needed ECMO, so we did a Seldinger technique for cannulation. This is the guide wire through aorta, and this is the ECMO that is running. It is central, it is through contour apertures, and even if wound is so complicated and a lot of things inside, we close the sternum, we close all soft tissues in a regular manner in order to perform sternal stabilization that will allow upcoming rehabilitation and that will allow to manage the wound for nurses, not only for surgeons. And the ICU management was also optimized, and we try to get any diagnostic or any needs of patients. We try to early extubate them, physical rehabilitation, and all maneuvers are guided and they are all written. So we may transfer the patient to any diagnostic. This is our patients, this is our institution's photos, any diagnostic in cath lab, and we try to extubate patient and to perform a physical rehabilitation of them, and even make them walk in order to be prepared to be extubated and self-maintenance. This is a girl with VSD and suprasystemic pulmonary hypertension, but she is now a medical student. And the other case is a gentleman with LVAD and severe right ventricular insufficiency. He was 5 months on support, even walking outside his hospital, and then he was transferred to operation, had the second LVAD, and discharged the hospital. The OR management, when we do a winning process and trial of the same multidisciplinary approach, it is planned procedure, everything is written, we scrub the patient, we total inactivate heparin right after, and we stabilize the serum with antibiotic impregnated sponge. We cannot evidence the effectiveness of that sponge, but we didn't see any bad from that process. So when you reopen the patient, the wound is pretty well, and you do not need anything else. It is clean, and the sponge we used in this maneuver. So if we will split the patients and just have a look only on central VA ECMO through all the period, we had 133 cases, very high number of bleeding, but as you see here in 2013, two lines of death and winning were crossing each other. And now death is quite stabilized, and I will show you the next slide. But the overall, we discharged 62% of patients that required central VA ECMO for post-cardiotomy shock. If we look deeply, sepsis is going like a death, because when sepsis is growing, number of deaths is growing. And the same is for multi-organ failure. They're quite equal lines of death and multi-organ failure. We try to call all the patients, and all data that we have is not all 133 patients. We were able to collect data only from 51 patients, but these are our long-term results, let's say 60 months. And we divided these groups of coronary artery disease, heart transplant, valvular heart disease, and congenital heart disease. And the results you see on the screen. So conclusions, temporary ECMO support is an acceptable option for patients with post-cardiotomy syndrome that otherwise will die. Multi-organ failure and sepsis strongly associated with hospital mortality. Good term survival or hospital survivals were shown on the slide previously. An improvement of outcome requires a program and multidisciplinary approach. That was the key for our results. Oops, sorry. Thank you so much.
Thanks, Timur. Great results. We have time for one short burning question. Otherwise, we move to the next speaker. Thank you.
Thank you. The next speaker, Dr. Thomas Strecker, is not present. So we're going to move on to the last presentation, which is the extracorporeal membrane oxygenation and lung transplantation. It's going to be presented by Dr. Erkin Yazisoglu. Please.
Dear Chairman, dear audience, I want to present extracorporeal membrane oxygenation in lung transplantation. Extracorporeal membrane oxygenation is an irreplaceable component of lung transplantation. From March 2013 to March 2017, we performed 30 lung transplantations, and a total of 20 patients received ECMO, extracorporeal membrane oxygenation. Mean age was 45 years, and 18 patients were men. And 90% of the patients received ECMO intraoperatively, mostly central venous arterial ECMO, and only one patient to peripheral venous arterial ECMO. 2 patients received ECMO in the intensive care unit. Of 18 patients who received ECMO, intraoperative ECMO, 9 were transferred to the intensive care unit with ECMO, and 8 received femoral venous arterial ECMO, and 1 received femoral vein to subclavian artery ECMO. Of 8 patients who received femoral venous arterial ECMO, femoral artery cannulation was switched to subclavian artery in 4 patients due to a better cerebral perfusion with using a tubular vascular graft. The demographic data of the patients are seen here, and systolic pulmonary artery pressure was 53 millimeter mercury, and the most pathology is idiopathic pulmonary fibrosis in ECMO-administrated cases. Of 12 patients who were transferred to the ICU without ECMO support, 2 received ECMO during follow-up in the intensive care unit. So a total of 10 patients needed ECMO support in the lung transplantation at ICU. Mostly we prefer veno-arterial ECMO and femoral vein to femoral artery was the most preferred one, followed by femoral artery to femoral vein to subclavian artery ECMO. Lung implantation with ECMO support has been one of the milestones of success in lung transplantation. ECMO in lung transplantation particularly allows a better recovery from primary graft dysfunction periods by decreasing elevated pulmonary pressures of the lungs, which cold ischemia is yet resolved. And therefore, ECMO should be considered in all cases with lung transplantation, with reversible causes. Indications of ECMO during lung transplantation is mostly high pulmonary systolic pressure, graft dysfunction, and followed by hemodynamic instability, pulmonary edema, intolerable patients to single lung ventilation during implantation of the contralateral lung, and in all reversible pathologies where we should think about ECMO. Of intraoperative ECMO applications, 94% were central, and it is preferred to maintain improved cerebral circulation and protect recently implanted lung from high pulmonary pressure. Subclavian artery cannulation has become increasingly preferred in the peripheral vein arterial ECMO applications, and it provides improved cerebral circulation despite a technically more complicated procedure. So, at conclusion, ECMO should be irreplaceable of success and survival in lung transplantation. Thank you very much.
That was time saving.
Thank you.
Great job.
Thank you.
Okay, so that's great. I think we can open the discussion for the whole session. So, and hopefully many of you will have different experience to share, and hopefully we will raise many questions. Maybe we can start with hub and spoke, because there were many topics on that. Go ahead.
We have different topics. We're trying to structure the discussion, and when we have different speakers start to talk about hub and spoke models with different countries, different definitions of the hub and the spoke center, and probably we can start with the first topic. And probably I have one question regarding in hub and spoke, is that my feeling that as many centers is doing it, which is reflects the needs, his demand, is probably working. Regarding how you are, time matters, and time means if we have, the time is going to be delaying time from onset of the onset, particularly in cardiogenic shock patient, to get patient back to restore the circulation. If you have that time prolonged, you're going to lose organs. And how the question for us now, and for the presenters, how they are training other centers or have non-CT surgeons to be able to at least cannulate and initiate ECMO. Do you have any experience with that?
Does it work? Yeah, it does work. Maybe a bit appropriate our experience in Croatia to take that, because that's a kind of principal question. What I noticed here in quite a few of presentations was a kind of notorious time on Lucas. And time on Lucas, well, my question, a counter question, what time on Lucas had been if that had been replaced time on ECMO instead? And that means that somebody, on the other hand, locally placed something more complications. So that's a balance of risk. So in our opinion, I think, because the most of physicians in the ICU, they do vascular access anyway. And of course, ECMO is just a specific or special type of vascular access. I think with a combination of aggressive training and aggressive simplification of the circuit, as Dr. Prince said, maybe not to put ideal ECMO first, maybe just small cannula, just to maintain blood oxygenation. We think is a better approach than to have patients in a specialized hub center with a mobile team, but already on 10 or 20 or 15 hours on Lucas. And then sometimes it's too late, or complication, death or complication toll is too high. But I mean, that's just, I open the discussion.
I think it is important. This is for resuscitation. So let's start with resuscitation, because it can be very different for acute MI-related cardiogenic shock, for instance. So for resuscitation, time is life, we know that. And for instance, in our center, when we have a call from a remote center for a patient who is on CPR for more than like 10, 15 minutes, and if the remote center is far away, we just deny the patient, because we know that time to organize a team, it takes about 20 minutes, go there, sometimes it takes like more than half an hour. The patient is going to be on CPR for more than 1 hour. So in this situation, we know the indication is quite futile, and then we just deny. So on the other hand, if we can train the other team to implant very small cannula, because again, then they should go for very small cannula to try to decrease the rate of complication, then it might work. The problem is that many teams, you know, they will have such a patient maybe 2 or 3 times a year. So training a team for 2 or 3 times a year, because this is not only inserting the cannula, this is also dearing the circuit and connecting. Even it is quite easy, you know, if the people are not used to do it, then you can have a mess as well. So the question is, how do you organize your own center, own country, just for resuscitation? Do you think we should use the mobile unit, or should we just train the other team to insert small cannulas?
I would like to add, there's a whole, the whole spectrum of shadows are gray. If you have 150, 200 kilometers away, patients with lactates were now 9, and still okay, he still doesn't need resuscitation. While you are assembling the mobile team, he might undergo resuscitation and get back on Lucas or something. That just there's no simple answer. However, we think that it should be combined, and we have a mobile unit ready, but in our reality, we didn't need to send mobile teams so far. However, we received some very, let's say, unusually placed ECMOs, in particular, you know, well, that's it. Yeah.
How is the situation in Regensburg? Is that how you manage that? I think that's not working. Probably here. That's it's not functioning.
So I think it's helpful. You have a team of 5, 6 people who are able to cannulate the patient under all conditions. We have realized that if we have the opportunity, then we take always a second doctor in our team. You can look, or we train him on difficult situations. That's very important. It's not only one you can do that. So we have a team of 5, 6 in our ECMO group, in the mobile ECMO group.
But you didn't train other centers to cannulate?
No.
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 And
I think we have center near about 50 kilometers. The best what they can do is they do sufficient resuscitation. That's more important than yes to cannulate the patient. They have a lot of damage on the cannulation by they are not experienced. We see that, and so I think the sufficient resuscitation is more important as we arrive any place and cannula are in patient and we are not sure the cannula are in the right place.
Did you train non-anesthesiologists to place the cannula in a patient, like internal medicine colleague? Do you have experience with that?
No.
No. And how much time you think you need to train anesthesiologists to be able to cannulate and to do that independently?
I think before he is doing cannulation self, he needs training in our center maybe 10, 15 times.
Under supervision?
Yeah.
And then he can go?
Then he
10
can
to
go
15 times?
Yeah.
Yes. 10 VV, 10 VA, or what's it?
I personally see no difference. If you do it VA or VA, you have the same difficulties.
And would you say that the difficulties is the same for a patient who is on CPR? Because for me, for a patient who is on CPR, sometimes it's even more difficult. The cannulation is even more difficult sometimes.
The main challenge under CPR is you find the right vessel, you decide early, you have to puncture the vein or arteria. That's the main challenge.
Yeah.
In our experience, maybe 10% of our patients, we have the cannula in the wrong vessel, and then that's not a catastrophic event. You recognize it very fast, and then you decide a new puncture for the arterial cannula. Fortunately, the most wrong cannulation is both cannula and the venous vessel.
Yep.
What's the main challenge you have with such a high volume program? Is resources regarding beds or money is an issue? Or what's the main, if you like, after that big experience you have, multiple years and hundreds of patients on ECMO, can you summarize this challenge you have now?
The main challenge, you find the right ICU bed for the patient. That's the limitation. We have in the totally 80 ICU bed in our hospital for all departments. So sometimes we block 10% of the ICU bed with ECMO patients, so we get difficulties.
This is a very important message for cardiac surgeon. Don't take care of those patients in the surgical ICU, because otherwise the surgical ICU is going to be fully blocked, and then there is no way to operate the regular patient, So this is very important, if there is an ECMO program in your institution, those patients has to be in other ICUs, but maybe not in the cardiac surgery ICU if you want to keep the program ongoing. That's very important.
So we have the interconnection.
And this is interconnection of care.
That's very important.
One thing, Ali, because you were speaking about to train anesthesiologists or to train other people, I think it does not depend of anesthesiologists, cardiac surgeon, cardiologists, and so on. It depends on the skills of the people, Anesthesiologists, some will know how to puncture, some will not, I can tell, not really the right way. Cardiac surgeons, some of us, we do have the experience of endovascular surgery, so we do know pretty well how to puncture an artery and put big things into the vessels as well. Some would not. And again, and then the training is very important. Do you use echo-guided puncture nowadays to make it safer? No. Yeah. So plan ECMO, yes, not emergency.
From my experience regarding the training, I would say anesthesia guys are easier to train than internal medicine. They are get used to place cannulas and place catheters in the patient more than internal medicine. It takes them shorter time to get them trained than internal. That's what my personal experience. I think surgeons shouldn't take a long time to just to get them familiarized with the technique and to do that. And in interventional cardiologists is the same thing. They should be able to do that. That shouldn't be a big deal. They're doing that in a cath lab. Femoral cannulation shouldn't be a big deal for them to get them again familiarized with the material.
Actually, I just read a hint or a very useful trick has been incorporated in our training scheme, and which makes the whole thing much easier, is a preemptive placement of vascular lines. Preemptive placement. So we encourage spoke centers to watch their patients. If there is any suspicion that patient might become unstable circulatory, we advise them to put preemptive line, and that's much easier. And that's very simple. Again, we're waiting between training scheme because we don't want to prove that we can do that. We have already proven that. We want as many people to be able to do that. That's a paradigm in philosophy that we apply in Croatia.
I agree with that. And even in non-CPR patients, I would say we do that for sometime in the OR when we think that at the end of the surgery it's going to be tough, then we just put 2 decilite in the vein and the femoral artery, even the reperfusion, so that if something happened at the end of the surgery, but even after the surgery, because sometimes the patients are doing okay after the surgery, but 6 hours after they just crash down, and then it's pretty good to have some decilite into the vessel just to be able to have a very fast implantation. I agree.
Just encourage the peripheral or district ICU to measure blood pressure on the femoral line instead of radial, that makes huge difference, trust me. Because you can use femoral line for wiring and put a cannula.
Regarding resuscitation with hub and spoke, any other experience to share? Timur, what here in Astana regarding resuscitation, how are you finally organized? Let us, because you did increase the number of ECMO you did implant, so in 2017, how are you organized?
We did increase the number of VA ECMOs, but that group is only the group from our center, and they're highly selected for patients after post-cardiotomy shock. Unfortunately, we do not have, in our country, we do not have a system and a network for introducing VA ECMO for cardiogenic shock or any other catastrophe, unfortunately.
Okay, so but it's going to come.
Yes.
Sooner. But you know, I think it's always the same story. You know, you start an ECMO program and that you get 1 phone call and then 2 phone call and then 4 phone call and then 10 phone call and then you get phone calls from everywhere and you have to answer the phone call because this is life-saving again, and you have patients on the other side. So sooner or later it will happen anyway. How did you many of you have a dedicated team for ECMO. How do you convince your institution to pay for that? Because there is a real economic issue. So you have
probably the state is different. The state is different, and the states we are. I would say in this way, and that's the data we presented that in one of our presentation in UCLA. The way we are doing ECMO, we are cannulating at the bedside. That's per se is going to reduce the amount of the operating room cost. Bedside cannulation, you're not going to the cath lab, you're not going to the operating room to cannulate the patient, reduce the cost. Number 2, we are not utilizing perfusionists 24/7, that's reducing the cost of that. Decannulation is the only process we are going to go back to the operating room. Reduce our complication to minimum. With that done, and looking to our cost compared to the way they were performing ECMO before we started there, we reduced the cost by 40%. And that's at our plus side. That means we are making money from our ECMO program. We don't have big burden from the reimbursement point of view. However, the challenge is in the bed situation in the ICU, because you are occupying significant number of beds. We have to fight. However, we're getting the support from the administration. There's no for any ECMO call. No no's. That will try to do everything to get room for that particular patients. But I'm sure there's different countries, different DRGs and different financial situation.
Yes.
My opinion, a very important point is you teach the emergency service. We come out. That's very important. The emergency service have to call, we have a problem, we have observed cardiac arrest, and then you have the option. You treat a patient outside, you load, the patient is unstable, you bring him to the hospital. Maybe this situation is standard, but the better way, in my opinion, is emergency service from outside. Call ECMO to him. The patient is not lift up, he is stable. You can very good basic life support. And then you implant cannula on scene. So the emergency service outside needs a feeling, or he has to mind, he has another option as you take the patient to a car and bring him to anywhere. Not to the specialized hospital, maybe bring him to a peripheral hospital. That's the worst thing for the patient.
The financial support, how is that paid in?
The financial part, in Germany, we get money for ECMO for every case if the case is in hospital. And then it depends on the time on ECMO. We have a basic fee, 6,000 euro for implant ECMO, and then it's increasing every 24 hours the patient is on ECMO, up to 1,000 hours. If the patient is 1,000 hours on ECMO, it's the maximum fee of 60,000 euro. You get not more.
60,000 euros.
It's not bad.
That's pretty good.
It's not bad, 6. You can live with that.
Yeah.
Any other questions?
So we move to another topic, monitoring.
Monitoring?
I think regarding monitoring, one of the main problems, one of the main issues is neurological complication. So you had very good talk about that, and I think, monitoring the complication once the complication occurs, it's okay, but it's too late. So I still don't really understand why some of the ECMO patients do have cerebral bleeding. They are doing well, and once in a while you have a huge cerebral bleeding or stroke, even if you have a peripheral cannula and so on. How can we prevent that? And just to start with, because I don't have that on the top of my head, do we have the same rate of thromboembolic complication I would say of cerebrovascular accident in VV patient than in VA patient? Would you say that this is the same rate of accident in VV and VA, or no? I'm not sure.
I think that there's a much higher rate in VA, in part because of what we've learned from peripheral cannulation, typically in cardiac surgery, that without a doubt there's, when you're perfusing retrograde up a aorta that often has a significant amount of disease, I think that sets you up for complications. One of the things that I think we're missing a huge opportunity on is to get a very good assessment of these patients before we put them on ECMO. There's so much emphasis on lactates and blood pressures and all the other physiology, but very rarely is there talk about their neurologic status before they go on ECMO. We just sort of assume that their brain is okay. And I think that some of the work on biomarkers, for example, I know at our institution, as soon as we get called to evaluate somebody for ECMO, the next call goes to our neurocritical care team that will come by and will do a very good detailed neurologic exam while we're working on prepping. And if at any point they raise the concern of a neurologic injury, then we just probably stop. And I think that part of the problem is that we're putting a lot of people that are already probably neurologically devastated on ECMO to begin with, and I think we need to do better at figuring that out, especially some of these patients that have had very prolonged downtimes, and even if they're getting CPR, it may not be good CPR, as I mentioned, in terms of blood flow with pressure and with oxygenation, and I think we need to do better at that.
I have some problem with the reporting the rates of complication without reporting the technology we are using. The impact of technology is important as well. Many of us reporting the ECMO without reporting which kind of oxygenator we are using, which kind of tubing I'm using, what the circuit looks like. Many are still using bridges between the arterial and venous side and connectors and so on. All that contributing to the problem we have with such kind of patients. And I think it's time now to start, when you're reporting about ECMO, to see what kind of system you're using. I'm using the CentriMag or Rotaflow. When we're talking about HeartMate 2 and HeartMate 3 and HeartWare, we have different results because of device technology. Why in ECMO we are not more specific in reporting these things now? We're reporting ECMO and say we have neurological events of 10, 15, or 20, or whatever. But we have now to start to be specific about reporting the things. You are reporting 10%, but what's your circuit that looks like? What's the level of anticoagulation using? And then we can compare. There's something we can prevent with miniaturizing the technology, with using heparin coating and all that things, but something we cannot prevent because of the pre-op or the pre-implantation condition of the patient. The patient came too late and have some problem before. However, monitoring is very important for me as a clinician working at the bedside, but also as important as monitoring to see what kind of system I am applying here and trying to minimize the trauma to the blood as much as I can, because that's going to produce another problem to the patient. And and even literature, if you review that, we're still not specific about that. That's something I hope in the future will be more specific about the things.
No, I agree with you. I couldn't agree more. In fact, there was a task force that was put together by ELSO about a year or so ago to try to at least develop a database of technologies so that when people were looking to develop their programs, they knew what was going together. And part of the problem was that there were just so many different permutations. I mean, not just, cannulas, pumps, connectors, length of tubing, oxygenators, where you cannulate, how you cannulate, and not to mention the sizes of the cannulas. I mean, I am amazed that, I'll get called to take care of patients on ECMO, and there'll be adult patients on VA ECMO with, 15 French arterial inflow cannulas that have just such enormous pressures through them that you have huge amounts of hemolysis. I mean, we're still struggling with anticoagulation, which may be coming from this. But I think that, there clearly is a huge opportunity to try to standardize some of these things to get an understanding of some of the complications, particularly with some of the different oxygenators and pumps that are out there.
But you talk about monitoring anticoagulation, and one question I have, the modern way to monitor anticoagulation is supposed to be using anti-10A, looking at anti-10A dosage and to adapt anticoagulation. That my feeling is that for patients on ECMO, it does not work, and sometimes we have what the intensivist says, the anti-10A is in the range, but the patient is bleeding, and if you just look back at the old APTT, then the APTT is very high, the ratio is very high. So what is your experience by using anti-10A in this situation?
We don't use it. I mean, I think maybe more in the pediatric world, they try to be very scientific of these things. But I think, with our adult population, and I think more and more people are just going by, PTTs and even getting away from ACT. I mean, we'll use ACT within the first few hours just to get started. And I'm constantly fighting with our perfusionists because I want it lower and lower and lower, and to the point where even stopping anticoagulation. I've had people on no anticoagulation, as I'm sure many people in this room have, for a week with no anticoagulation. You have such high flows, and the pressures are such that you're not going to. It's very rare to have problems.
Any other comment regarding the monitoring of anticoagulation? Ali, what do you use?
We have monitoring PTT and PTT and factor 10A, both of them.
And what is your feeling?
Sorry?
What is your feeling regarding both? Do you think both are very acceptable?
Feeling if the PTT probably is more, I'm relying more, because factor 10A started to do that, I have to be honest. Also, we're looking also to the clinical picture of the patient. Sometimes we have bleeding, and we have more bleeding complication than thromboembolic events.
Yep.
That's in our experience.
That's
why I am in reducing the heparin if I see any bleeding, and even to stop heparin. Because in our experience, we have very, very low rates of evidently thromboembolic events related to the act. But again, depends on the circuit you are using. We're using CenturyMac. We're using short tubing. We don't have bridges. We don't have bladder. We're not connecting hemofiltration to the circuit. It's a closed circuit, high volume, and high flow, and 17 arterial, 23 venous. That's what we're using, and quadrox oxygenator. That's the circuit we are using. And we have very low level of thromboembolic events on those patients. I have one question regarding patient now. Sometimes we're getting patient having hypoxic respiratory failure, hypoxemic respiratory failure, but coming to us too late on multiple pressors, inotropes, and the heart start to struggle. And those patients, we're putting them in VA. now we are rescuing some kind of hypoxemia to the brain. How we are going to monitor that and what level you're going to say, I can keep him, it is safe, and or you're going to switch to VVA or other way?
So, you know, I may be faulted for this, but I think if there's an assumption that a patient has a reasonable baseline cardiac function, and that you're not doing ECMO primarily in the setting of, let's say, an acute myocardial infarction, cardiogenic shock, then I usually go with veno from the very beginning, even if they are a little hypotensive and even if they are on some vasoactive medications. So I really try to restrict veno-arterial for those patients that are in true cardiogenic shock from some type of primary cardiac problem. Because I think once the patients that you describe, a lot of the reasons why they're in low cardiac output, hypotensive, whatever, is because they're hypoxic, they're acidotic, they're hypercarbic, and they have a lot of myocardial stunning. And if you're able to, as well as I think they have a very reactive, pulmonary arterial hypertension that gives them substantial RV dysfunction. And I think that if you're able to correct that with veno, then cardiac function can improve dramatically pretty quickly, and you can treat that a little bit with just minimal inotropic support to begin with and avoid veno-arterial altogether.
Yeah, that's great. I think we should try it, but in some cases, if it's septic and the heart is going to struggle for a longer period of time, and for any reason you're going to put with the VA on him, what kind of level and you're going to have because of the lung?
If they're stable enough, what I would do is axillary cannulation. I would take them to the operating room, and it takes a little bit of time, but with some practice, you can cannulate them, and that way even without opening the chest, that you can get arterial blood flow directly to the brain as well as to the coronaries. There's some groups, I think the Duke group has reported doing mini thoracotomies for cannulation, similar to what sometimes people do for direct access for TAVR. I have not done that myself. I think it just potentially creates more problems, but they've been very successful with that.
Let me ask the question another way. We have now septic patient, and we're going to give the VV ECMO. This cardiac output for 12, 13 liter, but you are going to give him 5, 6 liter from ECMO, and he still have some kind of desaturated brain condition. What kind of saturation you're going to accept to say, I'm okay, or he will be okay?
You take whatever you can get. I mean, I was amazed, during H1N1, where people were very septic, and even with 5 or 6 liters of flow, sometimes we had a hard time getting their saturations above low 80%, and I was amazed that many of them actually did very well neurologically. I think that if they're not making acid, and you can keep the perfusion going, with adequate sedation, and maybe even a little bit of mild hypothermia, you take what you can get. I think if you try to make things perfect, then you run into problems with bleeding and hemolysis and with a lot of other complications. I've seen some reports of people trying to control that response of the high cardiac output with very aggressive beta blockers. There was a report in JAMA, I think about a year or two ago, using esmolol. This had nothing to do with ECMO, but I think that they were able to dial down some of that cardiac output response. I've tried that a few times, and while the numbers are better, I don't know if that's had any impact on outcomes. So if a patient is saturating 80%, their PO2 is 50 or 60, and they're not making any acid and their blood pressure is okay, then I I just pray.
Yeah, I agree, 100%. We are accepting 80 and above on such kind of patients that probably for centers are doing BB ECMO, and so having such kind of condition might be some good teaching point. In Regensburg, the same philosophy, or 80% is okay? Pascal?
Yeah.
Yeah, so there's some point where
Yeah.
Croatia?
It's not the issue of the saturation, it's the issue of the oxygen content. And if even the low saturation with good hemoglobin, the oxygen content in blood is okay, and you just have higher extraction from the brain. So of course, there are some cutoff values. So we wouldn't go below 75, and then we do something there. But first, you should correct anemia. So we insist the hemoglobin above 100, always above 100. If it's below 100, then you can run into problems. And so that's our idea.
Yeah, I have to emphasize that because it's a constant battle in the intensive care units. Everybody wants to have, blood conservation therapies, and they tolerate hemoglobins that are very low. But, in this patient population, I think that there's growing evidence of having much higher hemoglobins, which only makes sense when you think about your hemoglobin as, the basic physiology of it. And, you get calls from your blood bank saying, well, why are you ordering blood, when your hemoglobin is already, 12, 14, 15. So we get it much higher, and I think there's evidence to support that that's beneficial, and it only makes physiologic sense.
A very good point. I think we have to insist on that we have to correct the anemia and to keep the hemoglobin higher than other patients, and even to fight with your blood bank, as you mentioned. Yes, 100%.
Regarding complication, can we tell a few words about the infectious disease of the lung? So we have many patients on peripheral ECMO, via ECMO, who do develop after a few days because they are in ICU, but I don't think this is only because they are in the ICU with the tube. And they do develop infection of the lung. Do you think we can decrease the rate of those infections just by, as soon as possible, trying to get some flow through the pulmonary vascular bed? Do you have any numbers regarding that? Any feeling? What do you think?
Well, I think that's why veno is better if you've got reasonable cardiac function, because my theory is that you're delivering very well saturated and oxygenated blood to the pulmonary arterial vessels, and then you have less of a VQ mismatch, you have better perfusion, and I think that prevents or minimizes some of the infectious complications, as well as then trying to maintain a lung protective strategy while preventing some atelectasis.
Is any side effects to be expected with running PO2 such high in the pulmonary circulation? Something you think about?
Yes and no. I mean, when I was looking at some of this, neurologic stuff, there is some basic science evidence to suggest that if you, and I think somebody touched on this before, that if you correct your PCO2 too quickly, that may result in some neurologic damage. And so there, I think some centers, I think your center has written about this, where you resist the urge to correct hypercarbia very quickly, and you try to correct it over 24 hours, I think is what you advocate. I think that's one aspect of it. I think that the concern of delivering too much oxygen, I think that's hard to prove, and I'd rather maybe have too much oxygen than too little oxygen.
Any questions on monitoring?
Monitoring lower limb ischemia, except clinical monitoring, do you have any Do you use the NIRS, for instance, to monitor the lower limb? Yeah, you do that in Regensburg. I think it is very useful as well, because this is a catastrophic complication when this happens. So, any other question regarding monitoring? Should we move to weaning process?
Weaning, yes.
Weaning. One thing regarding weaning, yes, we have this discussion with Ali before the talk. When we talk about when we try to analyze the results of weaning process, we should take into consideration that some patients are weaned because this is the best option. We think this is the best option. We think they are really winnable. And then if we fail, if they die, then this is a real failure. On the other hand, some of the patients, we do move to weaning because this is the only option. So then I would say might not be interpreted like a failure, because those patients, if there is no other option, particularly for VA, we think that after a few days or few weeks of VA ECMO, they are not candidate for transplantation, they are not candidate for a VAD or whatever, or TAH. Then, we just give, this is one shot, we just move to weaning just because this is the only option we have. So we should maybe separate that in the analysis we do regarding the results of weaning. What do you think about that? Any comment?
I agree completely with you, because nobody has ever separated or stratified those weaned patients to those who are primarily non-weanable but just weaned because there was no other option. And of course that's a burden to the whole results of the weaning, because there's a weaning in desperation, there's a weaning because we believe there's weanable patient, and that's absolutely right. We weaned quite a few patients because we couldn't do anything else. And then of course quite a few of them died, and then that affects our statistics. But again, I believe we have to go to basic philosophy. The basic philosophy is whether is a not acute resuscitation, whether is a chance for life, ECMO, and we believe it is, or whether it's a kind of adjunct to the therapy. If there is adjunct to the therapy, then it has to be evaluated compared to other therapies. If there is a chance for life, then it's compared to a kind of defibrillation. I mean, defibrillators went public. So what we do, back to the economic issue first, in Croatia, we, as you know, public system is publicly funded system, but we have here a National Health Service. We insist, well, not with much success now, but it's getting better and better. We insist on equality of chances. As acute and chronic heart failure is more deadly than most of cancers. So we would insist that patients with heart failure, they have equal chances of survival based on public funding. And that's, of course, is a little controversial policy, and it provokes some resentments from other groups, other specialties who won their case earlier on, especially from oncology case, because they won in 60s, the case that cancer should be always treated, regardless of. Some cancers that have a predicted mortality of 95% or 98%. Still patients are being treated with a lot of money invested. So what we insist now, there's equality in public system, that's equality of chance. I mean, in privately funded system, this completely probably is different. But in public, there's something that can increase the use of ECMO, and that's the reason we are pushing it to the primary resuscitation. Because this is just a kind of therapy. Said, okay, you can alternative therapy, but if we are giving chance for life, that's different. Of course, it must be simple and must be reasonably cheap.
Yeah.
But that's the way. And again, the simple paradigm. When I speak to public officials, I never speak about the mortality, because all patients placed on ECMO had already been dead. So I talk about the resurrection. And the last resurrection, my knowledge, been executed about 2,000 years ago, last successful one. and that's what we talk about, just to change the language. We talk about, we have a 40% of resurrection. And that, I mean, slowly is picking up, at least in Croatia. So could be advice for other publicly funded systems.
I just want to touch on a concept that you brought up, that's been brought up a few times, and that is the cost of all this. Now, you know, when the Caesar trial came out, they did do a cost analysis, and they found that, at least in the British healthcare system, and I know that every healthcare system is a little different, but at least in the British healthcare system, that it was a very cost-effective therapy for those patients that survived. And when they looked at the cost per quality year life, which is what policymakers look at, it is actually comparable to many types of other activities. In addition, when we looked at the costs and the expenses and the reimbursement of ECMO at our own institution in the United States, we found, one, that it was extremely profitable, which is nice, and two, the major expenses that come with ECMO are not necessarily the pump and the cannulas and the oxygenators. It's coming from taking care of a very sick patient in the intensive care unit for several weeks at a time. It's the ventilator, it's the operating room, it's the medications, it's the CAT scans, it's the x-rays. It's all the things that are going to happen separate from whether the patient is on ECMO or not. And so, ECMO is only a very small part of a very expensive hospitalization. And obviously, if you do it right, you can make money. And if you're not smart about it, then you can lose a lot of money. But it's something that's, I think, an important concept that we need to do better at when we're promoting this technology.
Something important you brought up.
You want to add something?
Yeah, go ahead.
I think you have two ways of cost. You have the ICU patient, he is treated as an ICU patient, and you have secondary cost, the ECMO cost. And you said the ECMO costs per se are not so high. You have the system, you have the cannulas, that's not a big amount of the treatment. And then maybe you have extra cost if the patient is a long time on ECMO. Maybe you need every 10 days in your system. But in the total sum, that's not the big amount. So the costs are really influenced by the treatment of the patient.
To put it into perspective, because all of these things are, and this is at a cardiothoracic meeting, so in the United States, cardio help, the cannulas, the circuit, the oxygenator, all of it together is probably maybe 12 to 15,000 US dollars, which is a lot of money. But if you look at the cost of an Impella, that's 35. Our hospital pays $35,000 for an Impella. A TAVR on a 90-year-old is $35,000. All of these, stents and wires and catheters and plugs and hemostatic agents and exotic medications, they're all thousands of dollars. Prothrombin complex to reverse anticoagulation is $5,000 a dose in the United States. These new drugs to reverse the anti 10A inhibitors, those are $5,000-$10,000 a dose. So when you start looking at the cost of ECMO, it's very small compared to everything else that's being done to these patients.
Regarding, I'm going to switch a little bit to the weaning, because that's the...
Sorry.
No problem. We have all the assumption and that probably assumption came from the early data on ECMO, we have to wean and take our decision between day 5 or 7 from ECMO. And that's something, and I don't think it's valid now if you're using the new technology and you can keep the patient longer on ECMO. That means if you're looking to the weaning, the time 5 to 7 should be not pushing you to wean the patient prematurely because of everybody saying 7 days you have to take your decision. We can keep patient longer now, but again, depends on what technology you're using. If you're using the appropriate technology, you can keep the patient longer on VA ECMO. And we have patients VA ECMO more than 30 days, and we're extubating and doing okay. That means this 5 to 7 days, number one, should be the reason to wean the patient. Number two is you have to place your weaning criteria in place and weaning protocol, and to know which criteria you're going to follow to wean this patient, because there's not too many published criteria on that. We publish our criteria for weaning from VA ECMO, echo, hemodynamics, and so on. You have to get it done. And if you look what's our data from Hershey, we look to the long-term patients weaned from VA ECMO. We have 80% after 1 year we're staying alive without transplant, without VAD therapy. That means you have to look to your protocol, and you have to not just look to the 5 to 7 days. And at the end of the day, if we have some patient now, he is not qualifying for VAD or total artificial heart or transplant, that's something we have to take the pill and say, okay, we have to stop the therapy or to wean. That's the last resort.
But that's exactly what we're all talking about. ECMO is not therapy. ECMO is just enabler. So we compare different diseases. Of course, the different diseases, they have different outcomes. Yeah. ECMO is just a second chance. Well, that second chance didn't exist. Now it exists. But if you cannot do within the time frame, if you cannot do anything, then nothing's going to happen, and that's it. So that's another reason ECMO to be classified not as therapy, but is it? For example, is it defibrillation? Is it therapy? That's not therapy. That's a kind of enabler, a tool. That's what our idea, ECMO to be considered as a tool. And of course, and then we can compare those with myocarditis, so either with ECMO or without ECMO. Those with primary heart failure, dilated cardiomyopathy, that's another group. Acute myocardial infarction, third group. Unknown, unwitnessed resuscitation, fourth group. Now we are mixing apples and pears, and then unfavorable. And again, we are not talking about resurrection. We are talking about mortality. That's another big mistake, in my opinion.
I disagree. I think, ECMO is a therapy. And I think that, if you compare it to dialysis, I think that there is enough literature to suggest that dialysis sometimes may actually be harmful to the kidneys. But on the other side of the coin, I think that there are many times that, ECMO can actually be, quite helpful for allowing the lungs and the heart to heal. And by, giving it time. And I think, the problem is that, we're looking at a variety of different disease conditions that some of them will get better and some of them will not. And the underlying question is, will they get better in the time frame that you can keep somebody on support for?
Well, still FDA is struggling with that. Is a tool or is it a therapy? I think
I have to say that, because now if you talk about dialysis, of course, has anybody ever talked about the mortality dialysis in cardiac surgical patients? No, we talk about mortality after cardiac surgery, and then patient had dialysis, and then patient had ECMO after cardiac surgery, and then we talk about the mortality on ECMO. There's the same mortality as mortality after cardiac surgery with or ECMO is a kind of adjunct to the therapy. I haven't read either one paper about dialysis mortality, and then combine mortality in ICU and on chronic. Have never. We don't do that, but we take ECMO and then we pile up, or we, let's say, pool mortalities for different conditions. So I think, anyway, that's...
Don't you think ECMO should be considered the same than mechanical ventilation or CVVHD. So if you say mechanical ventilation or CVVHD is therapy, then ECMO is therapy. Otherwise, this is not. Because I would say it's quite similar, you know, you just support a function for a short period of time, even if the short period can be for months sometime, but this is still a short period of time in the human life.
I think this discussion will going to go on either therapy or
Well,
it's a tool. Or,
but maybe something, because you talk about the duration on ECMO, and I agree that if the patient is not doing well enough on ECMO to move to something else, we should not move to something else. We should not rush. On the other hand, don't you think that if a patient is on ECMO for more than 10, 15 days, and finally the patient stabilizes and is candidate for something else, TAH, VAD, or transplantation, don't you think that this patient, even if he's stable, just normal lactate, normal biology, no infection, don't you think this patient, just because he stay in the bed for 15 days and he stay on ECMO for 15 days, he's a higher risk in comparison to a patient who just was on ECMO for 5 days and moved to transplantation or to that? Don't you think just being on ECMO for 15 days is more risky?
What I try to say is that is the patient now after 15 days, he is fulfilling your institution criteria to go for long-term VAD, I would not postpone the decision.
Yeah.
But I'm not going to go prematurely for VAD implantation because we are 10 days on ECMO, because we can improve him on ECMO. That's what I'm trying to make it clear. Because people are saying 7 days, after 7 days you're going to have a lot of complications there. Yes, in the past we have that. But I think with appropriate protocols, with appropriate technology, we can keep VA ECMO patient longer than the 7 or 10 days with acceptable level of complication if you trained your team to do that in the right way. That's what I'm trying to say on that. But if it's right, ready for after 10 days, go ahead. No need to keep him in ECMO.
Still on winning process, sometimes we do experience pretty bad septic shock after having weaned the patient from the ECMO and removing the cannula, even if we just infuse antibiotics and preventive antibiotics and so on. Do you have the same experience sometime after removing the cannula to experience septic shock? And no?
Well, what do you mean by, can you define septic shock? I mean, you know, there's hypotension and vasodilatation.
Well, that's most of the time associated with bacterium, yeah. Not always. Sometimes it's just recurrence of heart failure.
Yeah. I mean, I think the biggest thing that we sometimes see is that these patients often get quite febrile, and everybody's concerned that they're in septic shock. I think a lot of that comes from when they have their extracorporeal blood circulated for so long, many patients will reset their hypothalamic temperature regulation, and when you take it out, you know, they become febrile for several days. And I think that, you know, then, you know, when they get febrile and how you respond to that and how you treat it, and particularly if they're hypotensive, you know, for other reasons that may look like septic shock, but, you know, how many of these patients go on to have true sepsis from a bacterial or infectious source? That's hard to tell.
Well, it's a septic shock, and I agree on that. And those patients, is a patient coming from, you know, particular VV ECMO patient, if you are coming from home, and we're struggling more with cells, I would say, in this way, than patient having real cultures and so on. It's more cells than there's few cases with severe proven septic shock. Yes, we got some of them, and they're having a lot of a lot of problem, multiple pressors, very high dose of pressors, and we put them in VA ECMO in those patients. Some of them recovered. We have only problem with those patients because they are very, very high doses of pressors. We got problem with the peripherals, with the extremities because of the high doses of pressors. That few cases I saw and was proven severe septic shock. That we have few cases on that, yes.
But I think that gets back to your previous comments about having a better understanding of the circuits that are being used, because I think that if you look at, without mentioning any names, that if you look at some, for example, the different oxygenators out there, there are certain oxygenators that are much easier on the blood. There are oxygenators that have a much lower pressure gradient across the oxygenator, and then when you combine that, as I mentioned before, I'm always amazed that some people are using very small arterial cannulas, and I think that when you're driving blood at 5 or 6 liters per minute through a very inefficient high pressure gradient oxygenator through a relatively small cannula, then I think you're setting yourself up for a lot of these inflammatory complications that sometimes people see. Whereas if you have oxygenators that are much more physiologically compatible and you have large cannulas, then those are better tolerated. But again, I think that needs to be studied, and that's just my understanding.
I think that's a good point. Low pressure drop oxygenator and the cannula size and increasing your pressure if you measure your pressure at the arterial cannula, you know how high that with a different oxygenator and how much pressure shear stress you are applying to the blood components.
Well, not only that, but I've seen cases where when you have these, particularly for long periods of time, remember a lot of this technology is not approved, at least not in the United States, for prolonged periods of time. And I've seen some of these pumps actually start to melt, and and they don't just catastrophically fail, but over time they develop cracks and they start leaking, and you have to change them out. And I think with that, as well as some of the clotting that goes on, you set up for a huge inflammatory response that may mimic a septic picture.
One of the usual practices that we have in our department is to estimate the RPM to total flow curve. And then we increase RPM and then look at the total flow, and then just with the standardized with the standardized central blood pressure. And then see we saw dramatic difference in different type of oxygenators. And the dramatic difference. I mean, even those numbers, capillary, pre-capillary, post-capillary pressure, doesn't really match. But when you look at the RPM to the flow with the same cannula, a different oxygenator, you can see dramatic differences. And that's probably a kind of serious and very important cause of blood damage, and all those blood products that damage blood and can cause very serious trouble. In hemolysis, the free hemoglobin, because we saw differences in free hemoglobin between 50 and 250 and 300 with different oxygenator, and not much attention is being paid on that. Because of course nobody wants to get involved in conflict with the industry. Everybody comes and advocate their products.
Let me ask the experts here a practical question about how frequent and how you're looking for the hemolysis in the circuit. You're doing it daily, every second day. How are you monitoring that, and how frequent?
You mean like with a flashlight to looking for clots, or?
Well, how you monitor? Tell me how you're monitoring that, and how to try when you're going to change the circuit of hemolysis. Which criteria are you looking for?
Well, I think two things. One is we don't go looking for problems until they start manifesting themselves. I mean, if the patient is doing well, then there's no reason to kind of go looking after things. We do check liver function tests every couple of days, and if their bilirubins are going up or their hematocrit is going down and we're needing to transfuse them, that's a little bit of a different story. But I think with some of these newer pumps and these newer oxygenators, they are just, they're so efficient that, even if, when you drain them at the end and there's a lot of clots, that's not clinically relevant. We used to be very aggressive in changing oxygenators, 5 or 6 years ago whenever there was a blood gas that we didn't like. And now we've realized that, these oxygenators, they're never the problem, or very rarely are they a problem. It's usually something else. Maybe, colleagues in Germany can speak, I don't know what your thoughts are on it, but we rarely have circuit problems.
We have done in our center, we use routinely 3 different ECMO systems, exactly 4. But we see from the round speed of the pump, we see no difference between CardioHelp and Rotaflow. It's the same pump. So we have, for example, the Serene system, it's low rotation pump. For the same flow, you need, for example, 1500 rounds per minute. If you need the Meadows pump, it's 7000 for the same afterload. And if you take the CardioHelp, it's 3000. So in the end, we look for the free hemoglobin, for the drop of thrombocyte, for whatever. We see no difference in the system if the system runs well. We have no complication. But if we have complication, it depends not on the system. We have a clot in the pump head, then we see dramatic increase of the free hemoglobin. If we have clots in the oxygenator, we see dramatic decrease of fibrinogen on a high increasing of the dimer. So we check every day free hemoglobin, fibrinogen, dimer, platelets, and PDT. And it depends if we see increased free hemoglobin, 100% we have clots and pump bed. If we see increased dimers, we see, and the patient has no pulmonary embolism, of course, then we see always clots in the pump, in the oxygenator. The same decreasing fibrinogen, it's mainly triggered by clots inside the oxygenator. So we have clear criteria what a technical failure influence the lab parameters.
Pascal?
Well, I think we have the same experience. I'm not sure we do look at that every day. Guillaume might be no better, maybe every other day or every day, I don't remember, every other day. So we just look at every other day. But again, I think if the patient is doing well, clinically well, not too many things do happen. On the other hand, if the patient starts to have some complication, then we will see a decrease in the platelet, an increase in plasma-free hemoglobin, and so on. Many times, hemolysis to me is not really related to the device by itself. Many times the patient is doing well, there is no hemolysis, and after a few days or sometimes few weeks, the patient does experience hemolysis. There is no change in the oxygenator, no change in the diameter of cannulas. And if you really look at the patient, finally you find some sepsis, something going on, which explains as well. I think it's a conjunction of different things which brings to hemolysis. So it's not only one thing, but in many patients, sometimes if we have decrease in platelet counts, we do change the oxygenator, and I can tell. I was not believing in that, but I can tell it does. We can see after that with the new oxygenator that an increase back of the platelets. So I think after, it's not at the beginning, but after 7 to 10 days, sometime we see some consumption of the platelets or of the fibrinogen as well.
Does your platelet counts go up when you change the oxygenator?
Sorry?
Does that fix the problem?
It seems, yes,
Guillaume. Let me ask 2 questions. One, is it a problem? And 2, does it fix it? Because we see thrombocytopenia very frequently, and everybody gets concerned about hits, and we never see that.
No.
I mean, we would check. I remember doing 30 cases, and everybody got thrombocytopenic, and everybody went crazy thinking it was hits, and we started, our Gatraban or bivalirudin, and they were always negative. So then we stopped checking unless there was a problem. And even if their platelet counts went down to 60 or 70,000, we just leave it alone. I think we go chasing a lot of problems that maybe don't. I'm kind of a minimalist.
Well, sometimes it seems that, and Guillaume will correct me if I'm wrong, but it seems that it's happened again more with some circuits, some oxygenaires than with some others. So I would say some oxygenaires are more biocompatible than others. And sometimes, you have like 2,000 platelets, so sometimes, and in this situation, moving to another oxygenator just correct the problem, yes.
We are doing daily plasma-free and LDH, and I'm more concerned about hemolysis than I think drop in the platelets you find in every patient, and after a certain period of time is going to recover. That's HIT is very rare, like in our case. We some few, but it's not that common. And we're talking about keeping the patient longer in ECMO. If I'm going to wait to see the urine is dark, it's too late. I might have the problem with the SIRS-like problem because of the increase in the plasma hemoglobin. That's why I have to have good predictors to me when giving me some idea when to change and when to be careful and to be vigilant about changing some part from the circuit. That's why LDH and plasma-free is a good indicator for us to get in and trend them in a daily basis, looking to the performance of the pump. If your pump now running with 3,000 RPMs and you have 5 liters, next day you see, 3,000 and I have 4 liters. That's something also signal to me to say, you have to look at something here. You might have something wrong in the circuit. That's something we have to look on a daily basis on that and to try to be proactive. If you see the plasma hemoglobin 2 times started to go up, not to spend a lot of time and change the circuit. This is cheaper than to have a complication because of that. And you will be surprised that you're not going to have to change that very frequent and often. But I think it's a good indicator for us. Again, if we're using different system and different circuits, we have to have good monitoring to monitor such kind of problems before further complication to happen. Okay, you can close the session.
Well, I think it's lunchtime. So thanks very much to the speakers, to the experts. That was a very interesting session, and the discussion, was very, very important to me. We learned a lot of things through the discussion, and I will go back to my institution with a lot of things to improve or to test, and this is a field in which we do have a lot of things to improve. So have a good lunch, a good meeting, and see you this afternoon anyway.